All right. Well, it is now 3 o'clock exactly, so Eastern. So we're going to go ahead and get started. As I mentioned to those who joined early on, cameras and microphones are off during the speaker series, but you absolutely can engage via the chat. And we certainly encourage you to do so during Q&A, but also if you think of a comment or a question at any point during the session, feel free to pop it in the chat. We'll make sure to take a look at that during the Q&A. So I just want to take a moment before I turn things over to our speaker to make sure you have a good sense of the organization hosting today's seminar. Obviously, this is hosted, as you might guess, by the Interstitial Cystitis Association. We are the only national nonprofit in the United States dedicated to providing advocacy, education, and community to those who live with interstitial cystitis or bladder pain syndrome. We have two staff, so myself as the Chief Operations Officer, Laura Santuri, and then we have our Chief Executive Officer, Claudia King. Both of us are both professionals, but also patients who have both been living with the condition, I think both of us for over 20, 25 years now. So we also have a board of directors and a medical advisory council, and I think that's important to note that we are run by a group of people, both patients and professionals, who care very much about this community. Importantly, we offer a variety of resources in advocacy, education, and community. We are regularly engaging with our elected officials to advocate for awareness and research funding. In fact, we'll be on the Hill in just a couple of weeks. We have a variety of educational resources, our website, our magazine, we have a digital newsletter. We just implemented a new research newsletter, the ICA Research Digest, that went out this past Monday, that will be monthly, that I'm super excited about. And we have a very engaged community via social media, primarily on Facebook, but we're also on Instagram and LinkedIn as well. So please keep us in mind as a resource to you. Just a few logistical things about Google Meet, because I know there may be some folks who are newer to Google Meet. So if you want to use closed captioning, I know I'm at this point in my life where I don't even watch TV without closed captioning on. It's easier for me to follow. There's a little button at the bottom of your screen in a square that says CC. You could turn that on. It's actually fairly accurate. So if that helps you, you can do that. At any point, if you want to share a reaction, you absolutely can do so. There's a little smiley face and a variety of options there. Hopefully we don't say anything that elicits a thumbs down, but you never know. You've got the option. As I mentioned, the cameras and microphones are off, but you have access to the chat feature. So that little comment bubble at the bottom right of your screen, feel free at any point, if you have a comment or a question, to go ahead and put it in there, and we will make sure to take a look at it during the Q&A. And then finally, I always mention the settings, just in case, especially if you're having a hard time hearing or you can't hear. If you have your closed captioning on, you'll be able to see me say it. But if you click on settings, and you can kind of mess around with any of the settings, audio, video, etc., from that area. So just so you know how to kind of engage within Google Meet itself, I'm going to go ahead and stop sharing here. And at this point, I'm going to introduce our speaker. And Paulina, if you want to bring up your slides as I'm doing that, we'll get ready to turn things over to you. So I'm incredibly excited to introduce Paulina Sobel, who is the co-founder of the Pain Reprocessing Therapy Center and co-executive director of Well Body Psychotherapy. She is a psychotherapist specializing in the treatment of brain-based chronic pain. In addition to her clinical work, she has presented at various pain conferences, aiming to build a comprehensive network of certified practitioners to treat the millions who suffer from chronic pain. She spearheads the development of new initiatives, professional trainings, and educational resources to expand the reach of pain reprocessing therapy and improve access to healthcare professionals as well as patients. So I'm incredibly excited to have you join us today. With that, I'm going to turn the floor over to you.
Okay, thank you so much, Laura, and thank you everyone for being here and for your interest and for having me today. I appreciate the introduction. I'm curious if any of you want to type in the chat box if you have this condition yourself, if you're here sort of as a support or caregiver for someone else, if you are a practitioner treating bladder pain syndrome or interstitial cystitis. I would be really interested just to see who's in the crowd. No need, but I'll take a look. I see some patients. You've had this for a number of years. Okay. Okay, great. Well, hopefully I can give you some good insight today. As Laura mentioned, my name is Paulina. I am a licensed clinical social worker, and I specialize in the treatment of chronic pain. So I work as a clinician in my private practice called Well Body Psychotherapy. Here, I and some other fantastic clinicians treat chronic pain using this modality we have called pain reprocessing therapy. This is an evidence-based psychological treatment for chronic pain and other chronic conditions that I'm going to get into. We have seen so much success using this model. We've conducted some clinical trials that I'll be reviewing with all of you. And because of this, I actually went on to co-found a training center called the Pain Reprocessing Therapy Center. So I work with a lot of different types of mental health and healthcare providers who treat pain patients themselves. Our goal is really to expand the reach of this treatment so that patients can get the treatment they really need to recover. So I'm really looking forward to introducing you to the psychological model today and how it can help you struggling with chronic pain, chronic symptoms, including interstitial cystitis. So let me see if I can change these slides. Yes, okay, there we go. So the first thing you need to know about pain reprocessing therapy is what is pain. Pain is a danger signal. Pain is protective. And of course, pain is often unwanted. I see someone commented in the chat, I've had this for 20 years and it's really not fun. It is not fun. It is can be a very isolating experience and something that's very difficult to deal with on a daily basis. But what I like to stress is that pain is not all bad because pain is actually protective. Pain is necessary for survival. So I'll always give the example, imagine if you were to be cooking and you accidentally put your hand on the hot stove. What would happen is that nerve fibers in your hand would send a danger signal up to your brain pretty immediately. And your brain would generate pain. And this informs you to remove your hand so that you don't cause further tissue damage. So it's good that we have this danger signal. It's incredible that we've adapted in this way. And I like to give this example to kind of shift the perspective of pain right off the bat. Because of course, if you're living with chronic pain for many years, you probably see it as something that is all bad. Now, there's been a lot of recent research that shows that many forms of chronic pain are actually caused by learned neural pathways in the brain rather than structural problems in the body. All pain is 100% real. It is something you're really, truly experiencing, but not all pain comes from physical or structural damage to the body. And this is because the perception of potential tissue damage alone will cause our brain to generate pain, even in the absence of any real damage. So sometimes our brain will misinterpret safe messages from the body as if they were dangerous. And we have this alarm signal going off, but really it's a false alarm. And this type of pain is called neuroplastic pain. But what's interesting is that all pain comes from the brain. If you have structural pain, if there's something really, going on in your body, there's a disease process happening, then the body will send a message to your brain and the brain informs you of that damage. And with neuroplastic pain, the pain is simply a function of neural pathways in the brain. And sometimes our brain just makes a mistake and interprets danger where there is none, and it creates unnecessary or maybe amplified pain beyond what is being caused by the structural issue alone. So it is natural, it is our biological instinct to associate physical pain with physical damage. This is necessary for human survival. When we believe that we're injured or there is a threat, our brain can generate pain, and it can also generate anxiety so that we go into fight or flight. Fear, worry, dread, our brain can generate all of this. And the idea that physical pain may not be indicative of physical damage can be really counterintuitive. But what's interesting is that studies show a direct relationship between pain beliefs or fear and the perpetuation of symptoms. So when the brain interprets signals or sensations in the body through a lens of danger, it produces pain. And pain reprocessing therapy, we call it PRT, is a system of psychological techniques that tries to retrain the brain to accurately interpret and respond to signals from the body, to break that cycle of chronic pain, really correctly assess what is going on in the body and respond more appropriately. So we ran a randomized clinical trial that validated PRT as the most effective current treatment for chronic pain. And in this trial, of the participants in the PRT arm, 98% improved and 66% became pain-free or nearly pain-free. This was a month-long treatment course. The patients had 8 sessions, so they met twice a week. And these outcomes were really mind-blowing, to say the least. But what's even more exciting is that the results were largely maintained 1 year later. So these people didn't get out of pain for a short time. When they followed up with them a year later, they were still out of pain and their chronic symptoms didn't return. And right now we're running more trials with varying populations like the VA. And we're also trying to compare PRT to traditional pain management treatments. A standard psychological treatment for pain right now is cognitive behavioral therapy. And what we're trying to show here is that traditional psychological treatments for pain can really help manage symptoms, and there's nothing wrong with them, but PRT can actually eliminate symptoms. So our language is a little bit different. We can tell certain patients, based on what's going on with them and their medical assessment, that they can fully recover, that the chronic pain might not be something they have to live with for the rest of their lives and just manage or handle. So I use this treatment model PRT in its entirety when I'm dealing with neuroplastic pain or primary pain. So pain that is not caused by physical damage or disease. With primary pain, the pain is the primary problem. But I can also use components of this model to treat patients that do have underlying physical issues or disease. And that would be classified as secondary pain, where the pain is secondary to a structural problem. And with this population, the goal is a little bit different. I'm not going to cure this patient. I'm not going to entirely eliminate their pain. They might seek medical treatments alongside PRT, but I can definitely help reduce the severity of their symptoms. And that's because they might have this type of mixed pain, which is a combination of both the disease or the diagnosis and the primary pain. And this is because pain can become really amplified due to anxiety or fear or preoccupation with symptoms, which I'm going to go into more, but living with chronic pain can be really scary. There can be a change or loss of identity. There can be existential fears. There can be fears of, will this ever go away? Will I ever get my life back to the way it was before? Along with a lot of preoccupation with any sensation that comes up in your body and assessing it as if it could be dangerous. And what's unfortunate is that although this is a kind of normal, common way of responding, that response can actually perpetuate and chronify symptoms and make them more intense. So with IC specifically, it can affect anyone, but it's estimated that almost twice as many women have IC than men. But what was interesting in some of my research is that the numbers are not super solid. In some of the data that I found, it was shown that between 3.2 and 7.9 million US women 18 years or older have bladder pain syndrome or IC symptoms. And symptom severity and impact were comparable to those of adult women with established diagnoses. But of these millions of women, only 9.7% of them reported being assigned an IC diagnosis. So oftentimes, and you may have found this yourselves, IC is misdiagnosed, and you're given, the diagnosis of a UTI, but there's really no infection, or doctors can't really assess what is going on or don't really know. I also found that less men, but still a lot, 1 to 4 million men have symptoms of IC, but researchers really suspect that a lot more men have IC, but they've been incorrectly diagnosed with other diagnoses or symptoms. So as I'm sure a lot of you are familiar, symptoms might include bladder and pelvic pain or pressure and a frequent urge to urinate. And this can resemble a UTI, but oftentimes there is no infection present. So they can't really diagnose you with a urinary tract infection or treat a urinary tract infection. And really the cause of IC is unknown. And there's a lot of, informed guesses out there that this is related to inflammation of the bladder wall. But if someone has pain and the only known cause is inflammation, according to our protocol, they should be assessed for neuroplastic pain. And this is because the bladder is a master at self-repair. Our body has this incredible ability to heal. We've adapted in this way. And so when we're damaged by an infection or an injury, the bladder specifically can mend itself quickly. It can call upon specialized cells in its lining to repair tissue and restore a barrier against harmful materials that might be concentrated in the urine. And so if something like E. coli causes damage, the bladder should heal itself once the kind of toxins or infection is removed from the body. Our body really is adaptable and it has the capacity to heal. So if a bacteria, for example, causes an infection and this leads to inflammation, the inflammation might continue even after the bacteria is gone and the infection is resolved with antibiotics or whatever course of treatment you're getting from your medical provider. But what's kind of interesting is that the brain alone can then perpetuate the inflammation. And that's just because the brain perceives danger still existing to the body, even though the damage is gone, the damage is resolved, and the body is now safe. But our brain's perception or interpretation of danger alone can cause symptoms. It can even cause inflammation. And it's a protective mechanism. That inflammation is going to persist even when it is no longer needed, and it's now a false alarm. Now, something that we look at is assessing for and diagnosing neuroplastic pain. And I'm going to get into how do we really do that? How are we sure that this isn't a physical problem that needs physical treatments? Something interesting is, if doctors cannot find a cause, an underlying cause, if there's no diagnosis, that makes it easier for us to say, well, probably something else is at play here, the mind, if you have a clean bill of health. But there's also a lot of descriptive diagnoses. So even think about the name bladder pain syndrome. This is a descriptive diagnosis indicating pain in a certain part of the body, but not identifying a root cause. It's also found that IC patients have a high prevalence of comorbid diagnoses like IBS, fibromyalgia, any sort of functional somatic syndromes, which are also characterized by chronic pain, but in the absence of clearly identifiable pathology. And IBS and fibromyalgia, these are also descriptive diagnoses that say, widespread, maybe unexplainable pain without a clear cause. So this is just something I like to mention because having a diagnosis can be reassuring in some ways. Okay, maybe we know what's going on, but maybe all that's doing is that it's kind of describing what you're going through, but not really giving you an answer. Now, something else that I like to explain is that everyone has some form of mind-body symptom. I've never met anyone who hasn't gone through something like experiencing butterflies in their stomach before public speaking, right? Or getting a headache when they're stressed out, or their cheeks flushing when they're embarrassed, or their palms sweating when they're nervous. But unfortunately, for many, these mind-body symptoms stick around and they become chronic. And it is really not the patient's fault that it did. Pain produced is really primarily an unconscious process. And although it is the brain that can generate pain, that does not mean that the pain is all in the person's head. And I think with the patients that come to me, they often have some maybe rigidity towards treatment because they have been told that they're making this up or that it's all in their head. But the reality is all pain is generated in the brain, regardless of whether or not it reflects a physical tissue damage, a physical issue, or a physical injury. Pain is always an output of the brain, and pain is always real. So let me explain that a little bit further. This slide explains how pain is constructed by the brain. So to generate pain, our brain integrates sensory input, which is the blue curve on this slide, with internal predictions, which is the yellow curve on this slide. So sensory input is bottom-up processing. It's from the nerve endings in our body up to our brain. And this happens if you touch that hot stove. Sensory receptors in your hand send a message to your brain informing you of danger. And then internal predictions refers to top-down processing. So this is what you expect to feel before performing an activity. This is your brain's prediction about what it feels like to put your hand on that surface because of a past experience. And we learn this growing up. We learn a lot of this as children. And if we experience pain, we learn what to avoid and what to be careful around because we don't want to put ourselves in a high intensity pain situation. So then the middle curve on this graph, the green, is a combination of those two, and this reflects the actual pain experience. So it might not be only what's going on in the body, but also what your brain is predicting might happen or interpreting a sense of danger. And this top-down processing can really aid in developing conditioned responses. So if you expect burning or urgency with urination, or if you expect pain during sex, for example, it's likely that you will develop a conditioned response. And this is your brain's attempt at keeping you safe. Your brain wants to keep you out of pain, so it produces a lot of anxiety or nerves, high alert system, being in fight or flight around activities or positions or movements that have caused pain in the past. But the PRT model explains that that heightened anxiety or that heightened fear and danger produced by the nervous system can actually amplify the level of pain that you're experiencing. So instead of maybe with just that blue bottom-up curve being like a 5 out of 10, you experience a 9 out of 10 because of the predictions as well being added on from your brain. So there was a great TED Talk by Lorimer Moseley, if any of you are familiar with him. He's a pain neuroscientist. And I like to kind of give a little overview of his TED Talk because I think he explains it better than I do. So he describes the pain he experienced when he was bitten by a poisonous snake while hiking in a remote area. And it was a near-death experience, but thankfully he recovered from it. He was okay. And he decided to return to that remote area once again. This was a couple months, maybe a year later, to go hiking again after his injury had recovered and everything. And the next time he was hiking there, he scratched his leg on a twig. But the twig scratched him on his leg exactly where the snake had previously bitten him. And this time he was in agony. He's experiencing even more pain than when he was bitten by the snake. But really all that was going on is that he had a tiny harmless scratch and he was in no real danger. He had this little slight scratch. I don't know if his skin was even really broken or bleeding, but his brain really overreacted because of his previous experience of getting injured in the same location and in the same leg and being in real physical life-threatening danger the last time. So his brain made this association. The fairly neutral sensory input from the twig was associated with the danger of being bitten by a poisonous snake. And again, his brain did this in an effort to protect him. And so it amplified the pain. His brain learned to experience a high level of pain when feeling any sensation in his leg when hiking in this remote area. So there are a lot of research studies that demonstrate this idea, basically that the brain can increase suffering based on belief and fear and the presence of anxiety. And our brain uses this as clues, so that it can keep us safe. But sometimes it's just we're misinformed or our brain is misinformed. Now, when I talk about this top-down processing, it refers not only to internal predictions, but also general feelings of unsafety or the presence of threats in one's environment that can really increase sensitivity or hypervigilance. And fear and anxiety can sometimes exist outside of a person's conscious awareness, but it is stored in the nervous system. And so this fear and anxiety can come from, really, you name it, being in a bad or toxic or dangerous relationship, past emotional experiences, childhood traumas, being afraid of your boss at work, anything that causes you to have an overly active nervous system. And so our relationship with the world and our fear response is intimately connected with how we experience sensations in our bodies and our brain's threat predictions. And something else that's interesting that maybe some of you have been diagnosed with or have heard of is something called central sensitization. So this is the same as like allodynia or hyperalgesia, where you have an increased sensitivity to pain. And chronic pain can cause these symptoms or these diagnoses. So sometimes when we experience pain, our body learns to predict and anticipate and plan for more pain. And then our pain pathways become hypersensitive, making even mild stimuli feel more painful. So central sensitization is this condition of the central nervous system where it becomes hypersensitive and it overreacts to stimuli that are not normally painful. So there could be hypersensitivity to a sensation that doesn't indicate structural damage in this part of your body where you're feeling the pain. And so something even like a light touch or a slight change in temperature can trigger this severe discomfort. The brain will send this alarm system, but really there's no damage or real indicative damage to this part of your body. Okay. So I like to talk about this horror movie mode. Imagine how you feel if you're watching a horror movie late at night and you're home alone and it's dark out. If someone were to come and tap you on the shoulder, it might send you into a frenzy and make you anticipate the worst. Or maybe you see a shadow on the wall and it makes you think, there must be a stranger or a murderer in my house. When we're in this initial state of hypervigilance or high alert, we're much more likely to interpret neutral stimuli as threatening, even when they're not. So when we feel anxious or upset or hungry or tired or emotional, we're much more likely to view everything, including sensations, through this lens of danger. And this makes a lot of sense. I think I've said this a lot, but our brain does this in an effort to protect us. How can you not be in horror movie mode or anticipating the worst or anticipating more pain if you've learned to live this way? Once pain appears, usually most of us will respond with fear. But the problem is that fear reinforces danger to the brain. And then the more danger our brain thinks is present, the more pain it will generate, again, in an effort to protect us. And so it can feel really difficult to break this cycle. And this is why conditioned responses are formed in the first place. Our brain is trying to keep us out of harm's way. There was a study that was conducted in the Netherlands, and the purpose of the study was to determine if the presence of pain-related fear in people with, this study specifically was on lower back pain, makes the pain more likely to persist. So if they have more fear around their pain, will the pain stick around for longer? And so researchers recruited people with lower back pain and measured how much pain-related fear they had. And when they followed up 6 months later, the people who scored high on the fear scale were much more likely to still be in pain. And this was true regardless of how bad or intense their pain was or how long they had had it before the researchers came into the picture. And so the takeaway is that the more fear you have around your pain, the more likely your pain will continue. You'll get stuck in this cycle. This equation that we like to use, sorry, my cursor's over this, it'll go away, is that pain equals sensation plus fear. So our brain generates pain to protect us when it perceives a threat. And fear can be fear of bodily damage. Many of my patients and myself say, if I'm feeling this much pain, it must be indicative of something being off in my body. That's the purpose of pain. But fear can also be a more general sense of unsafety. So some of those ideas I mentioned, if you're feeling stressed about work or your relationship or moving or having a child or whatever it might be, anything that can sort of put your brain on high alert can amplify pain. So to some, I think the word fear can feel a little off-putting. I think many patients say to me, I'm really not afraid of my pain, or it's been here for so long, I know what to expect. I'm not afraid of it anymore, but I'm frustrated by it. I'm annoyed by it. So another word that you can substitute with fear is threat. And many chronic pain patients have the same fear, which is there has to be something going on in my body that's causing this. There has to be some form of threat to my body, and there's something that I need to address. And when the brain believes that's true, that the body is damaged or that there is a threat, it will respond with more pain. And fear of the pain, you might not use the word that you're fearful of the pain or you're afraid of it, but you're frustrated. There might be stress, despair, anxiety, hopelessness, annoyance, kind of anything that puts your brain on high alert. So sometimes I'll ask, whatever adjective you use to describe what goes on with your pain or how you react or respond to your pain, does this make your brain feel more or less in danger? Does this make your brain feel more or less safe? And if the answer is more danger or less safe, then it's a form of fear that falls under this umbrella of fear. Now, chronic pain can get totally wrapped up in a person's identity and sense of self. It can take them away from work, from family obligations, from sports, from hobbies, you name it. Pain can be so debilitating, and it can change the way a person sees themselves because it can really change the way they live their daily life. So I think once pain appears, a lot of different fears can come up for patients, like, will this pain ever go away? Or when will it go away? Or when will I go back to my pre-pain self? And those are kind of scary questions. So with pain reprocessing therapy, we have a two-pronged approach to kind of address everything I just presented in the first here. So we want to tackle fear. We want to maybe get rid of it or lessen it. But how do we do that? This is where PRT comes in. And this is our general two-pronged approach. So we want to address fear around the symptoms. So, whatever thoughts or beliefs or behaviors around the pain might be keeping the danger signals activated, which keeps the pain activated. So fear of bodily damage, fear of, is there something wrong with me? Is there something doctors are missing? How and when will I recover from this? And then on top of that, it's just fear of the way the pain impacts and debilitates someone's life and the way that it hurts on a daily basis. And then the second prong is addressing general fears that keep people in a state of high alert or hypervigilance. So this might be unrelated to the pain, but in the person's environment or social life, something that can activate pain signals or amplify sensations because you're being put into that horror movie mode. So pain can be amplified by that second prong, anything that falls under that second prong. So there's an amplification of symptoms. Imagine if you were wearing a hearing aid right now, or you're wearing AirPods listening to this presentation. And right now I'm talking at maybe a 2 out of 10, fairly quiet volume. But imagine if you cranked that hearing aid all the way up, then you would be hearing me at maybe an 8 out of 10 volume. Now I'm still talking at a 2 out of 10 volume. The input is still the same, but your brain interprets the sound as a lot louder than it is. And this is the same thing with neuroplastic pain. There might be, a 2 out of 10 physical disability or injury happening in your body, but there's a volume knob in your brain. And if the volume knob gets turned up, you're going to interpret the sensation as a lot louder than it is. And what determines whether the volume knob gets turned up or down is really how much danger your brain thinks there is. So if fear around your symptoms is really high, or you're more hypervigilant due to external stressors, then you might be interpreting sensations as louder than they are. And I'll focus on this with patients who might have an underlying physical issue or disease, that it's really possible to reduce the volume of symptoms. And we can eliminate symptoms that are not true to the disease. Although so many patients I see have truly neuroplastic pain without a physical cause that should really be causing their pain to persist. Now with pain reprocessing therapy, we have 5 main steps or stages. So I'll touch on each one now, and I'll go into them a little bit more into how we can really apply this model to your own diagnosis. So, okay, first we want to assess for neuroplastic pain. So we want to assess a patient for structurally caused or non-structurally caused symptoms. Then psychoeducation. The patient needs to be educated about how and why pain develops, why pain chronifies, and how fear fuels pain. And then next, you want to gather personalized evidence to gain buy-in of brain-generated pain. So kind of based on assessment criteria, how does your pain behave in a way that structurally caused pain might not? And then once evidence is gathered, then we can engage in pain safety learning, we call it. This is exposure techniques, somatic techniques to help reassess and reappraise pain sensations as safer than maybe the person once interpreted them to be. And then the last step is that second prong where we address other fears that might be revving up a person's nervous system. So general fears that turn on the person's danger signals, put them into fight or flight, and unfortunately amplify their pain, even though this fear might be kind of outside or unrelated to their pain itself. So the first step, if we dive into it a little bit further, is assessment. So I am a social worker, I'm a psychotherapist, I'm not a physician, and I don't want to work outside my scope. But we have come up with pretty good guidelines that help us rule in a neuroplastic diagnosis and give us clues into the possibility of neuroplasticity. And it might be important for myself as the therapist or a patient to work with a doctor, a medical provider as well, to rule out physical or structural pain. Usually my job is fairly easy in that sense because most patients have seen doctors before ever getting to me. I'm usually talking about ruling in neuroplastic pain because I might be more of the last stop rather than the first stop on someone's journey. So these are some of the diagnostic criteria I'm going to use to help determine if this person has pain that presents or behaves in a same or different way than structural pain would. So some criteria are symptoms started during a stressful time, or symptoms now increase and are worse during stressful times. Maybe the symptom began with no injury or long after an injury occurred. I see that a lot, that someone will say, well, I was in a car accident 20 years ago. I'm like, okay, well, I don't think that necessarily, most often, is still the cause of your pain because, as I mentioned, our body has an incredible ability to heal. It can be pain persisting after the normal course of healing. So someone might have an injury or damage to their body, and the doctor might give them a certain window of time. This should heal in 1 month, 3 months, 6 months, but now it's 10 years later and the pain is still there. Something else that's very telling is inconsistent symptoms. So symptoms move around the body, or they vary, or they behave in a way that normal acute pain does not. Oftentimes I see, let's say someone has back pain and their pain usually hurts when sitting, but sometimes it doesn't. They can find some inconsistencies in their pain presentation that can clue a patient into neuroplastic pain. So my pain almost always comes on when I do this, but last week I was doing it and I didn't notice the pain being there. That can be really good evidence. Something else is if doctors are unable to explain what's going on, if there's a lack of a diagnosis, or if there's only a descriptive diagnosis that's describing the pain that you're feeling, but not giving you an underlying cause. Multiple symptoms can be a very common trait that we see with people who have neuroplastic pain. They have, different types of chronic pain symptoms. So IC and fibromyalgia and IBS. It's more likely to have one underlying cause, which is the brain or our brain's misinterpretation, rather than many distinct, unrelated physical causes. Just kind of statistics. It's a lot more likely that this is all due to the same thing. We also often see triggers that are unrelated to the body that bring on the pain. So location, like where the person is actually located, time of day, weather. Weather is a big one I see with rain. Pain is there in the morning, but it's not there in the evening, even if the person is sort of doing the same positions or movements in the morning and evening. Something else that I'll try to assess for is, how does the patient treat themselves? Do they put a lot of pressure on themselves? Are they very self-critical or perfectionistic, or tend to engage in people pleasing? I use these examples because these are other behaviors that put the brain on high alert, where the person might be more attuned to scanning their environment for potential dangers or potential threats. And then what happens is we scan our sensations in our body for those potential threats as well. And then finally, I'll usually assess for adverse childhood experiences. Many people that have suffered trauma, and trauma, we say can be big T trauma, like something more dramatic, or little t trauma. Anything that really might have taught you to be hypervigilant, because at one time that was adaptive and it helped keep you safe in your environment. You being on high alert or being in a survival mode or a horror movie mode kept your system on high alert at all times. And maybe at one point that was really helpful to you in your life. And now you're in a different situation, but you've still learned to behave and exist in that same way. So I'll ask a lot of questions to learn about a person's pain and assess whether their symptoms are neuroplastic or maybe somewhat neuroplastic. And then I'll move to psychoeducation. And something I like to keep in mind, and maybe some of you have felt this, is that I find many of my patients have felt really invalidated by providers or by the people around them. They might have a little bit of distrust for the medical system because they've kind of been through the ringer and nothing's really helped them long term. So to make the transition with pain reprocessing therapy a little bit easier, because patients are giving a whole new treatment a try with a whole new provider, I really like to use analogies. So if I am describing the brain's misinterpretation of neutral sensations, I'll ask someone to imagine, for example, that they were to walk outside into their yard and mistake a garden hose for something threatening, like a rattlesnake, kind of coiled up, like in this picture. They would react as if there were a threat. And in the same way, the brain can misinterpret neutral sensations from the body as if they are dangerous, even when they might not be. And when we believe there is danger, our body produces pain. And that is not the person's fault, it is their hard wiring. And it can be important that the brain reacts in this way. There was another case, a famous case reported on by the British Medical Journal. It was on the case of a construction worker on a job site who accidentally jumped down onto a 6-inch nail, and the nail went through his boot and out the other side. He could see it. And he was in a ton of pain. He's in agony. He gets rushed to the hospital. But when the doctors removed his boot, they discovered that the nail went in between his toes and did not even cause a scratch. So his pain was genuine, his pain was real, but his brain generated the pain because he perceived that he was injured. And once his boot was removed and he saw that his foot was not damaged, his pain pretty much vanished. So I like to share research studies or stories or cases that might resonate with my patient and their diagnosis and their history, so that it's relevant to them. This is something I want the person to take in and accept and relate to. So I'll kind of try to uniquely tailor my psychoeducation to this specific person and help someone wrap their head around what is going on with them, because maybe this is something they've never heard of. Maybe they've never considered treating pain from a psychological perspective. And then the next thing that we'll need to do is evidence gathering. So we use those 12 criteria from the assessment from those 2 slides ago to gather personalized evidence into what is going on with this person and their pain, and make a evidence list. What part of this pain is behaving as though it might be neuroplastic or influenced by the brain? So I like to spend a lot of time here. We want to work with the cognitive brain first to help accept this idea of neuroplasticity. Because the reality is the only way to turn off the pain is if the person authentically believes that they are not in danger. If we can go into the body and do some somatic exercises with more authentic safety and reassurance and a newfound lens of understanding. So we really want to spend time gathering evidence so that we can go to this pain safety learning piece and I can show their brain that the pain is not as threatening as they may have thought. So with my patients, I'm trying to help their brain relearn and reappraise that pain is safer than they once believed. So there's a couple of ways to do this. Sometimes people, their pain will come on with specific movement. So I want to expose the person to the movement that triggers their pain or to the position that triggers their pain while practicing a lot of anxiety regulation. So as we prepare to go into this movement, does anxiety come up in the body? While we're doing it, while we're engaged in the movement, can we use some anxiety regulation techniques to calm down the nervous system so that that amplified piece of the pain is no longer added on to whatever is going on in the body, if there is something structural going on in the body. Sometimes people are really lucky and they don't have to do anything to make their pain come on. It's just always there. So with that, I'll just have my patients tune inward and watch sensations through a newfound lens of curiosity and interest, and maybe safety while they're stationary. And that safety hopefully can come from all the evidence they've gathered that their body is actually safe or safer than they once believed. Something else that I find can be really helpful is imagination work. So if someone's pain comes on while walking or while sitting or whatever it might be, in a session, I might do this sort of provocative testing, we call it, where I'll have the patient close their eyes and just imagine getting up and walking, and describe to me what that would be like, where they'd be going, if they're going to go out of their office or wherever they're sitting, through the door, into the kitchen, grab a bottle of water, whatever. Really imagine it, imagine all the details of it, and tell me, okay, what's going on in your body? Is there anxiety coming up? Is there pain coming on? This can be a really good assessment technique because you're not actually doing what triggers your pain, you're just imagining it. And if the pain comes on, it's a really good way to say, okay, we know that your brain is at play here. One other point that I'll mention is part of this treatment is teaching people to lean into positive sensations or joy. I think many times we pay more attention to painful sensations rather than good and nice and pleasant feelings, just because the painful ones tend to be louder. They take our attention more easily. So I want to encourage my patients to attend to sensations that they so often ignore. Sometimes I'll say, like, let's get good at feeling good. Let's lean into something in your body that authentically feels safe or nice, or let's expose you to something that authentically feels safe or nice, like running hot water, on your hands, or laying down on the couch with a cozy blanket, or petting your dog. Like, these can bring authentic feelings of safety, and we want to give our brain exposure to that, especially when it's been living with only pain for such a long time, and kind of focusing on that. And then the final step here that I'll explain is somatic tracking. There are a number of tools that we use with pain reprocessing therapy, kind of somatic techniques to reappraise sensations. But the most powerful and one of my favorites is called somatic tracking. And this method is aimed at showing your brain that you are safe by exposing you to pain in a new way. So to illustrate this for you all, let's say I'm home and I stroll into my bathroom and I see a big shadow behind my shower curtain. My first thought, if this were to happen, is there's a murderer in my shower, right? I'm terrified. Maybe I'll run into another room and I'll tell myself over and over that I'm safe, but I'm still going to be scared. I can't fully convince myself. I don't really know what's behind that shower curtain. I don't really know what that shadow was. So I can try to just keep hiding and just tell myself, it's okay. There's no way that there's someone in my house, but I'm still going to be scared. I'm still going to be on edge. If I build up the courage to go back into the bathroom and pull back the shower curtain and see that there is nothing there, then my fear will immediately disappear. So with somatic tracking, this is what we're doing. We want to expose ourselves to what we are afraid of in a safe environment to see it for what it really is, and then change our response to it, knowing that it is not so dangerous. And when we begin to respond differently without fear, then the pain loses its fuel. And this might not be right away, but over time, because pain is a sensation plus fear. So there's three components, three sort of steps to somatic tracking, which are mindfulness. This is attending to a sensation with less fear or judgment or specific desired outcome. And then safety reappraisal. This is communicating safety to remind ourselves that we're not in so much danger and that the painful sensations are not dangerous. And someone needs to draw on their own evidence list to find messages of safety that feel authentic or genuine to their situation, which sometimes might be as simple as, this is temporary, this pain spike will pass, or I'm safe, my body is healthy, my body is not damaged, whatever sort of safety messages really land authentically for that person. And then finally, we want to interject some positive affect. So this is essentially my job as a provider to find a way to lighten the mood. When you engage in a somatic tracking or any sort of somatic exercise with pain, the goal is to attend to the sensation with curiosity and effortlessness and ease and some lightness, instead of paying attention like you were studying for an exam with intensity and pressure and fear. So you might want to do this with imaginal exercises where you're sort of imagining yourself on a beach or on vacation or in a place you really like that makes you feel safe, using that positive imagery, or your provider might tell stories or make jokes, any way to sort of lean into the body while in a lighter, easier, more effortless state. So those are sort of the nuts and bolts of pain reprocessing therapy. I hope that was helpful. I put on here just our website and our email address so that you can get in touch with me if you have questions. We do treat IC quite often with pain reprocessing therapy. So this is something that we're pretty familiar with at my practice. And I would be happy to take some questions now if anyone wanted to put them in the chat, or maybe you can just shout out. I'm not sure.
Yeah, absolutely. Well, first of all, we'll do the virtual round of applause. It's always a little less dramatic on the virtual space, but thank you very much. That was an incredibly informative presentation. All right, so we've got, and so the folks, our cameras and microphones are muted, although I'll tell you what, I can actually change that. So I know, because sometimes it's a little bit hard to type in questions, but we'll feel free to type in, and then I'm going to see if I can change it so that you can unmute and ask questions. But I know we have a question here. Can you take patients remotely? That's our first question.
Yes, actually our practice is fully remote, so everyone is seen remotely. I know some people want to be seen in person. So yeah, we see people from all over the world, honestly. So yes.
Fantastic. We have another question. While doing somatic tracking, I need help reducing my distress when I'm feeling pain. Any suggestions?
Yes. I mean, that's a good question. You definitely do want to reduce your distress, right? Because the goal is to kind of shift from this felt sense of danger more so to a felt sense of safety. So the best time, I didn't really explain this, to engage in somatic tracking is maybe when the pain is not at an all-time high, because it's really hard to feel safe when you're in a really high intensity level of pain, or just your fear is really high. And so if you're noticing that it's really hard to kind of set aside the fear and lean into something that feels safe, I would have you do a somatic tracking for a different sensation. And it might be the breath. It might be a nice, pleasant feeling in your arms or your legs when you're laying down relaxing. And we kind of call this leaning into positive sensations. This can be almost a back door into somatic tracking, because you want to give your brain the experience of paying attention to any sensation in your body through an authentic lens of safety. So I might even practice that before going to the painful sensation.
Great.
That's helpful.
We had another question. What is your practice's success rate of treating someone with IC?
Good question. We don't have actual data on the specific diagnosis, so I don't know. But in our clinical trial, the success rate was really high with using pain reprocessing therapy for chronic pain. We had 98% of patients improve and 66% were pain-free or nearly pain-free. We haven't run a trial or really collected data specifically on this diagnosis, so I can't say. But I think what's interesting about PRT is that the same approach can be used with people of all different diagnoses, pain in all different parts of the body. I actually conduct groups where I'll have maybe 30 patients who all have a different history, but I'm pretty much treating them in the same way. So I would tell you that the results from the study should kind of correlate with whatever chronic symptom you are experiencing, whether it's chronic back pain, IC, chronic fatigue, or IBS. That's helpful.
Great. And a somewhat related question, we have someone who says, if anybody goes on to the clinic from or for therapy, would your organization agree to anonymously let us know of the results so we could know the outcomes? So, of course, no pressure there. Although I would, of course, in general, be curious about your experiences working with IC patients.
Yeah. I don't. Yes. We might have to get a release from the patient, although we wouldn't send any identifying details.
Right.
But it would be really interesting to actually collect that data. So.
And the ICA has in the past, and we have some plans for the future, we do occasionally do patient panels where we have patients speak to their experiences undergoing different types of treatment strategies. So there's no reason that we might not at some point in the future have a panel of patients who are talking about these types of interventions and how they compare and how their experiences compare to experiencing other treatment strategies. So that's certainly something that we could do as an organization as well. Good question. Do you work with main insurance companies? And has this type of treatment been approved by insurance companies, given how hard it can be to get treatments approved? Or is it out of pocket?
Great question. So with my practice, and I do believe most other practices, it is unfortunately out of pocket. If you're working with a therapist in your state, we can provide a super bill, although our practice does not accept insurance. Like I could provide a super bill for a patient in California of just providing, 50 minutes of psychotherapy that then they could submit to their insurance. So oftentimes if you have mental health benefits with your insurance, you will get a reimbursement. But unfortunately, we don't accept insurance directly. I wish we did, but yeah.
Got it. Thank you. How does this relate to the book, The Body Keeps the Score, with experiencing multiple life trauma and with the nervous system being on overdrive?
Yeah, great book. It definitely relates. I think that book is talking about how trauma is stored in the body. Sometimes it's unconscious, and I think the way that it's unconscious is also a protective mechanism. I've seen really interesting research about how people literally forget, they have no recollection of what they have been through because it is way too damaging for their brain to replay it or think about it all the time. And then maybe through this intensive therapy, it gets revealed and they remember it. But I think that relates to that second prong of our treatment, where if you've been through something traumatic, whatever that might be for you, that will cause you to have an overly active nervous system, that will cause you to scan your environment for potential threats at almost all times because you needed to. And that was helpful. But the problem is that we are communicating that we're in danger all the time. And maybe now, if you're in a different environment or situation, things are different. Maybe you're not in danger all the time, or maybe there's pockets of safety in your life that you can find where you can more kind of successfully practice these techniques. Because when we scan our environment for potential threats, then we include sensations in our body and maybe preoccupation with sensations in our body under that same lens and under that same umbrella. And so, of course, any sensation is going to have that added layer of fear on top. So it definitely correlates. And sometimes patients will do a more involved trauma treatment, like something like EMDR. There's a lot of great trauma therapies out there in conjunction with pain reprocessing therapy. And I think that can be really beneficial.
Fantastic. So we are at 4 o'clock Eastern exactly. So I do want to make sure that we are respectful of everyone's time. Before I wrap things up, if folks have continued questions about your therapy or your center, what would be the best way for them to reach out to you all?
Great question. So my private practice is called Well Body Psychotherapy. The URL is getwellbody.com. So that's a great way to get in touch. We have a contact form there. If you search pain reprocessing therapy or pain reprocessing therapy center, that's also a way to get in touch with us. I'm happy to share those email addresses or those links if that's helpful. But Get Well Body and pain reprocessing therapy, those are both us, and you can get in touch with us there.
Excellent. And if anybody, if you can't find them, please feel free to email the ICA directly and we'll happily get you connected. Before we close out, I just want to remind everybody to stay connected to the ICA. There are lots of different ways that you can do that, whether it's through our website, staying in touch and reading our digital newsletters or our new research digest. And we have a very active and engaged community on Facebook especially. So just a quick reminder to stay engaged with us. And if you have questions at any point, don't ever hesitate to reach out to us. Our general email is icamail@ichelp.org. But you can also find Claudia and I's information as well online. So we're always happy to answer questions or be of help. But thank you all again for joining, and thank you very much, Paulina, for an excellent presentation. Another digital round of applause before we close out. Thank you, everyone. Have a wonderful rest of your day.